Hey guys, this is Ryan, and you're listening to Curbside to Bedside. Today we're here with Floyd and Dr. Lubbers, and there has been some kind of a little bit of a flurry of back and forth on Twitter and social media and some other places over a 2010 study called the FEEL study. And the activity on Twitter is in regards to some extrapolations that were made from the study regarding the management of cardiac arrest. And Floyd and I, being the astute Twitter addicts that we are, saw that Walt was involved in kind of the opposition argument to some of the points that were being presented. And we would like to get Walt's thought and explore his vast and superior doctor mind.
I made it almost the entire way through that intro.
This is
Almost.
the second time on the show.
He is not a stranger. He is still a generous lubber, as evidenced by his presentation here today. I was trying to think of more puns on the drive up here as to use your name, and I'll probably think of more throughout the show. They're just not going to make any sense.
Fire away.
I'm sure you've heard all of them.
The well's never dry.
So the FEEL study.
Study.
How do you feel about the FEEL study? More importantly, what the hell is the FEEL study?
Boy, you thought the jokes couldn't get any worse, huh? So the FEEL study, FEEL, which is Focused Echocardiographic Evaluation in Life Support, FEEL. So what this is, they're referencing the stuff that I was talking about, a 2010 study. So bear in mind, before I said anything else, this damn thing is 8 years old at this point. The study itself is 8 years old. And this is a German study from 4 German EMS services, and this was based on data collected between 2002 and 2007. So literally the thing is 16 years. The data that we're getting from this is 16 years old.
The study data can drive.
Yes. Yeah. And usually I would say that, well, that may not make that big a difference, but I think it might have a little bit of bearing on this one.
I think the other big thing is that it's a German study, and their out-of-hospital model is entirely different from the U.S.
That's true. So that was one of the big things on this study that allowed them to do some of the stuff they did. Basically, so they did an ultrasound, the emergency physician that rides in the back of a German ambulance, which they've all got. And it's not emergency medicine like board certified emergency medicine like you think of here. It's an anesthesiologist or a critical care doc or cardiologist, somebody like that, who has actually had EMS, essentially fellowship training. So you start off, doing your board certification in whatever, anesthesia or critical care. And then you go and you do some pre-hospital training, and then you become a pre-hospital doc. So we have pre-hospital docs, but it's a little bit different. So that's sort of important to point out. Nonetheless, so they have these guys riding around in the back of an ambulance, the standard teams. And these guys would go out and do pre-hospital ultrasound. And this was a big thing in 2002 when most ultrasound machines were still the size of kind of a washing machine. They'd go out and they'd do some pre-hospital ultrasound. And the indications they used for in this study was, number one, if you were in CPR, they implemented this FEEL protocol, which is basically familiar with like a rush exam or a fast exam. It's the same kind of thing. That's what the FEEL part's coming into play. And they would look for in cardiac arrest, cardiac motion, ventricular function, RV dilation, or pericardial fluid collection. Of note, they didn't look at the lungs, which is something that we've sort of started to do, and I think is probably fairly important for a lot of the cardiac arrest that we manage. And then they also looked at the impact of echocardiographic information on management was documented. So that's quoting them. Basically, they said, look for this stuff, see if it influences your management, and then tell us if yes or no it influenced your management. That's the basis of what it was. Basically, it's German ambulance goes out with a doc in the back and you do an ultrasound on anybody in CPR. And there's some other ones that they did in the peri-resuscitative state, but we can just kind of ignore those because we can all agree that ultrasound in a living person who's just really sick is helpful. So I think you can kind of ignore the rest of that part.
I think it's important to realize that from the outset, the study design and the stated study question for the FEEL study was feasibility of out-of-hospital echocardiogram. That was it. Is this something that they can do routinely? So what we're going to diverge from now is some of the secondary conclusions that have been kind of postulated from the secondary outcome data of this study, which academically is interesting. But we'll get into the points of practicality that are being made and then the kind of rebuttal against it.
So did they find that pre-hospital folks could accurately perform an ultrasound?
Theoretically, yes. The guy that was doing the ultrasound is, again, an emergency physician or carries the title of emergency physician. So there was no actual, like, somebody went back and re-QA'd all the studies or anything like that. It's assumed that if you're carrying that title, that you're essentially a subject matter expert, or at least very proficient in being able to do so. So basically, you just take whatever findings they said they found and assume that that was good image quality and that nobody would fudge or anything like that on it, which has its own limitations, but whatever. So they were able to get ultrasounds. They ended up ultrasounding 100 patients in cardiac arrest. Of interesting quote, no central pulse was palpable in 97 patients. So the other 3 patients, I guess, were alive and they just started doing CPR on them or something like that. It's just kind of weird. And this whole paper is full of those little, like, what are they talking about kind of things.
I thought I've read that too. And my thought, just to kind of play devil's advocate, was maybe they had a severely bradycardic patient that still had a palpable pulse disgranted at, once a year or something like that. That would be a situation where I would probably start CPR too.
It might have been, but then I would say they couldn't call, because the big point of this is that they're going to look at PEA and asystole.
Yeah.
Like shockable rhythms, everybody knows what it's going to look like, or at least they think they know what it's going to look like. So these guys focused on PEA or asystole. So if you have a pulse, it's not actually pulseless electrical activity, nor is it actually asystole. So I was a little bit confused by it. Long story short, what they found was they had 51 people in PEA. And also of note, the numbers in the text don't line up with the numbers in the charts. And there's about 12 people that are somehow chilling out there unaccounted for in either one of the charts or in one of the text. So you can't say 100%. And I think that actually makes a difference in a small study where a difference of 10 people is 20% of your whole sample size.
I'm glad that I'm not crazy for noticing that.
Yeah. Which starts to tick off some of the reasons I don't like this study, in that it's a little bit sloppy. In that way. Now, maybe they're actually out there and we just don't know about it. But okay, so German ambulance, doc in the back, does an ultrasound on anybody in cardiac arrest. And what they ended up with was a sample size of 100 patients. There were other ones that they did, again, that were not in cardiac arrest, but we'll ignore those for the moment. 100 patients, 38 patients in asystole, 22 in PEA, sinus rhythm 8, and SVT 5. So relatively straightforward. But then they only documented 24 patients in VF, which 24 patients in VF would be the right proportion. But the numbers don't line up still. So anyway, 100 patients. And they mostly looked at PEA patients because shockable rhythm, it should look like VF. There shouldn't be a real big debate about that. What they're wondering about is what happens when you talk about the PEA patients. So they were able to obtain ultrasounds in all these guys. They said generally the image quality was good, as you would expect from a doc that's supposed to be a subject matter expert in the area. Of the folks that were in PEA, they said that was about 51% of the sample size. They said of folks that are PEA, meaning there's organized electrical activity, about 75% had some cardiac motion with that. Now, they never go to really define what cardiac motion is, but you're left to assume that's some sort of twitch or something in the myocardium. And
it's a very nebulous definition and when you actually read the methods, it's a very nebulous definition of what cardiac motion is. It's everything but basically passive blood flow through the heart, as I understand it.
And on this one, you can't really say because they didn't explicitly define it. It's just left up to the doc in the back says, yeah, he had wall motion or he didn't have wall motion. But we don't, that's certainly not to say that there was a coordinated squeeze or anything like that. It's just there was some cardiac activity. And then there were various reasons that could have happened. Of note, they attributed the PEA state to about 10% of patients to be from tamponade, which seemed like an enormously high number in a small sample set. I know I've resuscitated more than 100 people and put a lot of ultrasounds on people, and I've maybe seen one tamponade in that, not that long a career, but enough to say, yeah, I feel like I've been around the block a little bit. It seems like an incredibly high number. Maybe Germans are just that way.
I think, and this is my own theory, that maybe the reasoning goes is if they're detecting tamponade on people that have active CPR ongoing, maybe it wasn't necessarily tamponade, but the reasoning was they have pericardial free fluid, they are in arrest, ergo, it's tamponade. Which would kind of be erroneous from a physiological standpoint, but I can see where that makes its way into a definition.
Yeah, and I think if you did it like in the setting of, am I going to intervene on this? Yeah, maybe there's reason behind it. If you got some fluid, it's maybe an intervention you might do. Maybe it's got an effect on it. But it definitely didn't sound like, at least from the descriptions and from everything they said, it didn't sound like it was the classic, RV wall bows in, and you have a hyperdynamic heart that's just kind of sitting there twitching because it can't get around the big fluid sac.
No, and this study also excluded traumatic arrest as well. So there's no, how many people just have a walking pericardial tamponade? Yeah. Most of your truly clinical pericardial tamponades are the result of some force of trauma.
Yeah. That's basically what I mean, is that in each, if you go to the fire station and pick out 10 guys, that means one of them right now is walking around with a big pericardial effusion.
And the other thing it was buried in here somewhere, but I remember reading it, is that a few of the people that got included in the tamponade section were the result of finding electrical alternons on the EKG. So I think that was what they might have excluded a few of those patients.
Gotcha.
When they didn't find any pericardial free fluid. But I think that was one of their indices of suspicion if they found it.
If that many patients in cardiac arrest did have cardiac tamponade, then that would be a compelling reason for us to get ultrasounds on every ambulances and start doing pericardial centesis.
I think it absolutely would be. I mean, that would be compelling enough to just say everybody ought to get a blind pericardiocentesis, not a blind pericardiocentesis, right, but just like
empirically.
Yeah. 10% of the people out there got it. Hell yes. Just everybody should be getting a needle in them.
That'd be a low number needed to treat right there.
But like I said, I don't think that necessarily holds up.
Yeah, the way they defined it, and they only defined it in the legend of one of the graphs. It was CPR plus a pericardial effusion.
So we've got the numbers, and it seems that a lot of patients with PEA actually have some type of wall motion, right? Whether it's coordinated or not. But it seems like a lot of patients are actually in pseudo PEA.
So yeah, 73% of these guys that were in PEA, which you talk to a lot of people and you think like, oh, PEA just means there's some electrical activity and there's not actually, the heart's not really moving, it's not trying to squeeze or anything like that. Yeah. And that's probably kind of an older, more naive idea of what PEA actually is. So they bring up the idea that maybe there's this pseudo PEA thing where your heart's moving, but it's not generating a pulse big enough or great enough for you to feel.
They're just in severe shock, basically.
Yeah. It's hard to tell, they don't really break out like, yes, there's coordinated movement of 75% of the hearts, or it's just like there's a little twitch of 75% of the hearts. They just say there's motion there. In 3/4 of cases where there's some organized electrical activity, there's some sort of movement of the heart. And that was the sort of definition at that point. Interestingly enough, if you had some motion of your heart, you had about a 55% chance of survival to admission. And if you didn't, you had about an 8% chance of survival to admission. And they didn't go any farther into the hospital, like survival to discharge or anything. It was just, did you survive? Basically, did you get ROSC and survive long enough to get a hospital bed?
So for a lot of paramedics out there, the assumption is PEA equals just random electrical impulses and absolutely no cardiac wall movement because you can't feel a pulse. And that does not appear to be holding up as a theory in a lot of the data that's coming out from cardiac arrest research.
Yeah, and as Floyd, you kind of said there too, you could think of this as some of these patients are maybe just in really bad cardiogenic shock and their heart's still trying to beat, but it's just not. So of that, they said about 60% had reduced left ventricular function, which would be that one that you're talking about, just the really bad cardiogenic shock kind of picture. There were about 8% that had a dilated RV, which makes you think that maybe this is a
possibly
PE. There were the aforementioned 10% that they diagnosed with tamponade, for better or for worse. And then they found 2 patients that they thought had still cardiac motion, but were so hypovolemic that they couldn't generate a pulse. So they can help kind of break out what the different flavors of PEA were. And really that's where PEA is kind of at. It's like, it's not a thing per se. It's not really a diagnosis. It's more of a statement of the general condition of the person, and not really like this person has PEA, therefore they died. It's person was in the state of pulseless electrical activity due to severe RV dysfunction or RV outflow tract obstruction because of their big PE.
And that's generally how my thinking has changed in terms of from my graduation from paramedic school, is that PEA is an indicator of catastrophic shock. Now we need to figure out why. And basically, this is shock declaring itself, and it's up to me to run through the differentials in the clinical picture and try to figure out maybe why this patient is giving me this information.
Which this leads into what I'm wanting to get into is aside from cardiac tamponade, which we as ground level providers in Kentucky can't do shit about anyway. I'm sure some paramedics in some states out there can.
It's a not so subtle shade that was just thrown.
Aside from cardiac tamponade, what benefit would it have as a ground level provider to be able to differentiate between like actually true PEA, i.e. electromechanical dissociation, and pseudo PEA, where there's the patient's just in such profound shock that we can't feel a pulse? Would it change our management?
I think you'd have to be a pretty forward-thinking guy and really have a lot of tools available to you to really make a difference. Because, like you said, you could do a pericardiocentesis. You probably could, but you're not allowed to. I think it could, if you had something like an obstruction due to what you thought was a tension pneumothorax, you could do something about that. Although that's not mentioned in the study, that's not listed. It's just me.
That's not what they looked at.
Yeah, no, they didn't really do any lung ultrasound studies.
Didn't do any at all. Yeah. And that's okay. Are you going to fix the PE unless you have lytics like on board, which some ambulances in some places do, but unless you're going to do that, no, probably not. You might give them a little fluid. The one thing same thing with like, okay, they've got depressed LV function. Could you theoretically sit and wait and instead of doing more chest compressions, put this guy on more of an inotrope?
Start throwing milrinone at this guy.
Yeah, or put him on dobutamine or something like that. But then that means you're going to get your dobutamine ready, and are you really going to stop chest compressions to start dripping in some dobutamine or something like that just to see if you can get some more forward flow because you don't want to use epi? You can still use epi, but it may not be the best drug for it.
Yeah, and I think that most of the time we're still going to have to perform CPR because we don't really have any good tools to make the determination of whether or not perfusion is adequate enough to stop CPR, irrespective of whatever the ultrasound findings are.
Yeah, unless you were to use like essentially Doppler to see if there's just a wee little bit of flow. But even then, if it's only palpable or if the flow signal is only found by Doppler, like you said, the chance that they've actually got enough flow to perfuse their brain or perfuse their kidneys or whatever it is you're trying to perfuse is probably not there to start off with.
So if you have shitty end tidal and no pleth, it's probably just okay to assume that you're not in a flow state that's permissive of the amount of perfusion to the brain that meets physiological baseline.
Yeah, and so, I was going to bring up the SpO2 pleth and end tidal CO2. A lot of people would say, well, if you can't feel a pulse, then the pulse probably isn't strong enough to produce a measurable SpO2 pleth or one that the monitor will pick up. And I don't really think that's true because we suck at feeling for a pulse anyway. So I think it's good practice for every patient in cardiac arrest that you just put that SpO2 probe on. And like, hey, if you do a rhythm check and you've got an SpO2 pleth, then the patient's heart's beating.
To jump on that point, which was, okay, say that it's not a blood pressure issue. Say the person actually is mounting a blood pressure. The argument behind PEA, maybe PEA is not really a good thing, or maybe this is what pseudo PEA actually is that you're actually, when you really start talking about pseudo PEA, it's probably that entity itself is probably more you're actually mounting a blood pressure that you can perfuse stuff with. You just can't find that pulse for whatever reason. And so, like, quick lit review on how sucky we are at kind of finding pulses. There are a couple of studies. Everything's kind of been done pre like 2005 thereabouts. There was a couple of studies in the late 90s where they basically put people on bypass and then had either paramedics or EMTs or EMT students come up, put their finger on them, see if they had a carotid pulse. The finger sensitivity for pulselessness, meaning to say that the person doesn't have a pulse, is 90% sensitive, but only about 55% specific. So that means that 45% of the people had a pulse, but it wasn't detected by the feeler, and about 10% had no pulse, but the feeler said that they did. And maybe more to one of their points in the bigger part of their study was actually that it took about 24 seconds on average to get an answer and about 15 seconds to even find a pulse when it was there. Like, you knew it was there. It took them 15 seconds to be able to feel it and about 30 seconds to show that a pulse wasn't there. So if you're going to do a pulse check, you're supposed to get it done in ideally 5 seconds, maybe 10 seconds. These guys are saying that realistically in a controlled setting, you can't even get it done in 30 seconds for the most part. In fact, 1 out of 59 people identified the absence of a pulse correctly in less than 10 seconds. So 1 out of 59 of us can actually follow the goals and say, yes, there's no pulse.
That's pretty
impressive.
damning evidence in terms of our own confidence and ability to palpate a pulse.
Yeah.
Kind of an aside, but you hear a lot of people, especially in entry level, so like EMT or the beginning parts of your paramedic school, warning you against you to treat the patient, not the monitor. I don't think what necessarily is pushed on is that when you look at the actual scientifically validated dissection of our clinical exam findings, like true physical touching the patient clinical exam findings, they're not that great. Our telemetry is a way to inform our clinical decision making. So things like what Floyd was saying earlier, using the pleth wave to determine the presence of a pulse. You will not get a pleth wave if you do not have a pulse. Personally, I don't trust my fingers when I'm dealing with a patient that's either in extreme shock or in arrest.
And I think that we're all in agreement that an ultrasound won't significantly inform our decision making of whether or not we should continue CPR in a patient in PEA with some cardiac activity. Dr. Lubbers brought up a good point about how much we suck at feeling for a pulse. What I do and recommend to others is that during CPR, while you're preparing for your next pulse or rhythm check, stick your finger on the femoral and find the pulse that's being generated by CPR so that you can shorten that pulse check.
And I think that's a good practice, good way to kind of go about it. I think, honestly, the thing that this study is good for, it's been held out as like it's potentially practice changing by some folks recently, although again, it wasn't practice changing 8 years ago, and I don't know that's all that practice changing now. But what I think it does say is kind of to what you were getting at. Like if you have point of care ultrasound, you drop it on the guy's chest during your pulse check, and you don't get in the way of anything else. If you see a heart that's, really squeezing, like really going to town, you're like, oh man, I bet there's got to be a pulse there someplace. Give me a minute and let me try to find it, because we're not very good at it and it takes us a while. Okay, let me try to find that. And if you give yourself more than that, just a little initial like second, you might actually be able to find one, not only for you to get more in place, but also if you think about you've just been doing a bunch of CPR, you probably squish the heart. It's got to take a couple of seconds to actually fill and then start doing some forward flow. So it's probably going to take a few seconds before you actually feel it. But if you drop the probe on there, I think the one thing you can take away from this study and say, yes, this is useful, is that like if you can see it, take a couple extra seconds and be like, yeah, maybe it's actually there.
Yeah, maybe there's something to this.
Yeah, there's not a whole lot that you're going to do about the little slightly quivering heart, as you guys kind of said, like it's going to be all that different. But maybe you just take a minute to say like, oh, we can avoid doing 2 or 4 or 10 more minutes of CPR on these folks. And of note, that's just the PEA side. Mm-hmm. There was more to the study, if you're interested.
And I'm ready to get into it.
That's sweet.
What we're about to get into is kind of the whole reason we wanted to do this podcast. So we talked about one side of the study, which was like the PEA side. What was the other side?
The other side, the other non-shockable thing you have is asystole, or a clinical, initial clinical diagnosis of asystole. So these guys, in folks that were deemed based on their EKG to have asystole, there are about 37 of them out of, again, about 100. They found that 35% when you put the probe on them have wall motion. So somebody that should have no electrical activity in their heart that you can tell, actually they said the heart's moving about 35% of the time. And to go back to the survival part, if you had wall motion and you were in asystole, you had about 24% of those guys survived to get to the hospital. And if you didn't have it, then same thing, only about 11% did. And of note, they do kind of say like there was ongoing coordinated cardiac motion for asystole. Like that was kind of brought up. So maybe it's not just the twitch, although that's never really mentioned anyplace else. I don't know if you can 100% say that that's what they were looking for. So what is that probably? If I had to guess, I'd probably say it's like a fine VF or something like that. Or maybe it's what was being attributed to be a artifact or something along those lines. And maybe there was actually a little bit of cardiac activity with it.
Or like, what about passive blood flow? Like after you do a few CPRs and it comes back over the valves.
As everything is kind of layering out, that potentially could be it too. You would hope that they wouldn't have just looked at valve motion, because that can change all over the place. Like if you shake somebody around, their valves may move a little bit. And this is where I kind of mentioned before, like think back to 2002. If you look at even the ultrasounds that like I trained on when we first really had some smallish computer-sized handheld ultrasounds that you could take around. If you look at the picture on that compared to the picture that that you get now, it's like looking at a 1 megapixel camera versus like a 10 megapixel camera today. The image quality is just so much better now. So then that was like 2010 that I'm talking about. This is 2002, when we were still pushing around, carts, and most of the people traveled by horseback.
Ultrasound machine the size of a cinder block.
Yeah. So could that may be a little bit more difficult to tell whether or not there was actual like cardiac activity, or if this was just blood flowing in it, or if maybe there was an artifact to it. Again, you assume that based on their criteria for being part of the study and being the emergency physician, they're assumed to be right. And if you give that to them, then you say like, oh yeah, they're okay, cool. 37% of those guys that should have had no electrical activity in their heart and therefore no contractility actually had some sort of motion, they thought.
So again, should this change anything? Because a lot of people, and this isn't even what the study, that this was not the intended purpose of the study, but a lot of people are extrapolating this information and saying that because this many patients in asystole actually had some wall motion or were in VF, they're saying that we should just empirically shock asystole.
So in answer to the question, should this change your management? No. Because what the f- are you going to do differently? You can put a beep in there, right?
Nah.
Okay, cool.
No, he doesn't beat my cups, so no reason to change it now.
So seriously, but what are you going to do differently about it? Are you going to say that because there's there's the chance that this may be a little bit of electrical act, or there may be a little bit of motion that we can't really tell based on a now 16-year-old study, that we really ought to change the way that we're practicing? I don't think so. Even if, and this is probably the thing that you really want to talk about, like even if you have a super fine VF, that your eyes, as good as you are, and our monitor technology has stayed kind of the same. It hadn't gotten all that much better. You could still see, squiggly lines. Assuming that your monitor, or assuming that your person reading it is competent to see what VF looks like, even if it is fine VF, if you hit that with a bunch of electricity, the chance that anything good right now is going to come out of it is probably pretty small. And there is a risk associated with it.
Especially if it's so fine that it looks like asystole.
There's a really awesome doctor, and if you haven't heard of him right now, you should probably go and just look at everything he's ever put out there. And this is no offense to you, Walt, but he's a cardiologist. He does a lot of very in-depth research on cardiac arrest care. And a lot of it informs our decision-making that we make now, or that we at least use to help guide our decisions now. And basically his overriding theory, which to me makes sense, is that at this stage in arrest, there is not enough ATP in the heart to make a meaningful difference if you shock that rhythm. So course VF, we can theorize that at the start of arrest, you have a baseline physiological amount of ATP to power your cells. And the longer this arrest goes on, the finer and finer that VF gets, and the lower and lower the ATP level in your myocytes becomes, because they have no way to further generate electricity. So one of the things he did was he looked at a porcine model of induced VF. So there are basically two groups. There was a group of pigs that had VF induced, and then no CPR for 3 minutes, Floyd.
I think it may have been longer, but anyway, they had one group that did not get CPR for a long time.
It was a prolonged amount of time.
Yeah.
If I were in a room with a patient and we had a VF arrest and we weren't doing CPR, I'd be profoundly uncomfortable. So basically, they had a prolonged amount of time where this pig was in VF. And basically, they just watched the waveform. And then they tried to shock it. And this is the type of science that I think is pretty cool, because they're just basically, they induced VF in these pigs and they let them sit in VF for a while, and then they tried to convert it. What happened in the group that had no CPR and then electrical defibrillation delivered was that they had basically unilateral conversion to asystole. There was no real encouraging results there. Juxtaposed to the intervention group, which had VF induced and then 3.5 minutes, I think, of CPR delivered prior to an electrical shock. The electrical shock was delivered and they had much better rates of conversion to a sinus rhythm, which lends credence to the theory that, as we all learned in elementary school, the mitochondria are the powerhouse of the cell, and what fuels that cell, or that powerhouse, is ATP. So the theory being that you do high quality CPR, you circulate existing stores of ATP, you get that into the myocytes, and then when you deliver a shock, their ability to actualize that ATP into a organized rhythm is realized much greater than just shocking a low functioning metabolic state.
Just to kind of summarize and clarify what Ryan was saying, Dr. Kudenchuk gave this lecture that we're going to share in the show notes. He referred to a study where they induced VF in pigs for about 10 minutes. They randomized them to defibrillation after 10 minutes without CPR and 3 minutes of CPR after being in VF for 10 minutes. Those who were in VF without CPR for 10 minutes did not survive. Those who had 3 minutes of CPR before the shock did survive. Interestingly, the VF waveform after performing CPR for 3 minutes visually looked like the VF waveform that you initially saw in the video. He also showed a video of a heart that was in VF with very poor rigor. You could barely see it fibrillating. They shocked it into an organized rhythm, but the vigor or the strength of the contractions after that shock were so poor that you almost couldn't see it beating or differentiate between the VF and organized contractions. They then performed CPR for 3 minutes and shocked it. After that, you could clearly see organized, strong contractions. So the whole point of this is to demonstrate that if the VF is so fine that it looks like asystole, it's not better to deliver a shock just in case and because it can't hurt. Because you absolutely can make them worse, and you're increasing the amount of hands-off time when you could be doing some high-quality CPR and increasing your chances of a successful defibrillation.
That's the thing, these people aren't dead. Like, they're in cardiac arrest. They're in a state where they're, like, you could just call it like profound shock if you wanted to call it that. But these guys aren't dead because dead means dead. Dead is unresuscitatable. You can't bring somebody back from the dead. Somebody in cardiac arrest who's not quite dead has a shot. You can work on those guys. If you think the person's dead, like if you're going to say this person is dead, then what you ought to do is leave their body alone, stop wailing on them, go ahead and call the coroner. Because if they're dead, then you can't do anything about it. These guys aren't dead until, this is going to sound weird, but, or, gung-ho or whatever. They're not dead until we say they're dead.
Which I really like.
Yeah, everybody's got a shot.
Because maybe that's my kind of just altruistic, let's give everyone a fighting chance. But I think there is a very large problem in EMS with this institutionalized nihilism when it comes to resuscitation. From EMT school, I remember, well, you can't really fuck up during a code because they're already dead. But as we go through and we explore the science and we explore the literature and as we advance our understanding of cardiac arrest care, the more pale that thing becomes in the light of day. Because there are things that we can do that will have meaningful outcomes. Like these people can go on to live meaningful lives if we do our jobs. So the theory that you can't do any wrong because they're already dead doesn't really hold any water in my eyes, because like Walt said, they're not dead until we say they're dead. That kind of comes off with a little bit of bravado, but I like it because it's not untrue. I can't pull Granny up out of the ground 6 months after she died and resuscitate her. But if you code in a bank in front of 20 people and get high quality CPR and you have VF on arrival, we should probably be able to get you back. That's an encouraging physiological state for return to good neurological outcome post-arrest. So there are things that can be done in that situation that will either help or harm that patient's chance at an outcome.
To that end, absolutely. Yeah, I think when you talk about, like, is there harm? For everything we do, there's a risk and there's a benefit. What's the benefit of shocking a fine VF that you maybe can't perceive as different than asystole? Well, the benefit is maybe that you terminate that VF, and then maybe it makes it a little bit easier for there to eventually become electrical activity coming back in the heart, or organized electrical activity, I should say. What's the risk now? Well, the risk is that every time you shock the guy's heart, it's just, why do your chest muscles hurt after they get shocked? Your myocardial tissue does kind of the same thing. And actually, when you apply an electrical current to it, you actually open up all the membrane channels that, sort of keep the heart beating, all that stuff that keeps the sodium on one side and allows all the conduction to actually occur. You actually open up pores in the cell membrane and destroy that barrier. So if you look at somebody that gets like maybe not a defibrillation shock, but like a cardioversion shock, you find the beats that occur after that, and this is a heart that's still beating, of course, the beats that occur after the shock look really weird for a while. And it's not uncommon to go into sort of funky dysrhythmia or what looks like sort of midi-ventricular rhythm or something like that.
I've seen that in my awake, previously unstable post-cardioversion rhythms where they were in like AFib with RVR and they got a high high energy cardioversion that was successful, and then they go into this almost reperfusion arrhythmia looking wide, bizarre, just kind of like, oh shit.
Yeah.
Like, what did I just do? But now they're awake and talking to me rhythm, so I'm not going to mess with it.
And that's a heart that still has energy stores. This isn't a heart that's been in arrest for, at that point, like you said, probably 10 minutes, 15 minutes, something like that. This is a heart that was beaten, the guy that was talking until a second ago that we just, we put him out just for this procedure. In the heart that's been down and is already hurt, it's probably, my suspicions is probably significantly worse because you have no ability to kind of do any of the reparative stuff, or reset those, close those membrane pores, or reset your channels or anything like that, because the heart's, it's already out of energy. So if it's that low down, if it's that fine a VF that you can't tell if it's VF or asystole, that's a heart that probably needs something else. Now, if you did it, if you saw that, yes, there's absolutely a fine VF in there and you tried to shock it, okay, cool. If you see it, feel free to treat it. Because what you're presumably going to do is get back on the chest and do another 2 minutes of CPR and then maybe another 2 minutes after that. Then you're probably going to go from if you were successful in terminating the VF, you might go for 2 minutes of get asystole. And then 2 minutes after that, you start to get an organized rhythm back. And then 2 minutes after that, you actually get a little bit of perfusion back because you do eventually have to stop that fibrillation if you're going to get if you're going to get an organized rhythm back. If you see it, okay, treat it. Just go ahead and take care of it. That's one less thing you got to worry about. That's probably not that big a deal. It's the fact that we're talking about empirically shocking a heart that doesn't need it. And just like everything else, if you empirically give bicarb in cardiac arrest, survival is worse. If you empirically give glucose in cardiac arrest, survival is worse. If you empirically give too much oxygen to somebody who has a bad heart or who's in cardiac arrest or in a big MI, survival is worse. All this stuff, none of it is without that risk-benefit ratio. So if you see it, treat it, absolutely. If it's not there, you're not going to do anything different with it anyway, other than continue to do CPR because you got to get some flow back to this guy's heart. Why would you expose them to the extra risk of the electrical shock?
And I don't think that that's the only risk. I think that another risk that we could talk about is prolonged interruption. I think the field study cited an average of less than 10 seconds of interruptions in CPR, but which is
highly impressive. However,
and that's not what a lot of the current data is saying.
Yeah, for out of hospital point of care ultrasound, the studies that have been done since have demonstrated very long, unacceptable pauses in critical interventions such as CPR to gain ultrasound studies.
Yeah, like this. There's one in Resuscitation in 2017 by, I'm going to murder this poor name, but it's Huis in de Welt, which is an awesome name, by the way, whoever you are out. So out of 123 pulse checks, the average length of a pulse check using an ultrasound machine was 21 seconds. And the average length of a pulse check not using an ultrasound machine was 13 seconds.
Now, if I took 21 seconds of pause to intubate someone in cardiac arrest, people would burn cities down.
Costs you 18% every 5 seconds after your first initial 5 seconds in terms of survival. So your first 5 seconds you get free. 5 seconds after that, odds of survival goes down 18%. Next 5 goes down 18%.
Which is
next 5 goes down 18%.
Absolutely unacceptable. Now, I will concede that some of this may be a byproduct of training, and that if you can train someone to a standard, and if you can make that a goal to minimize your interruptions less than 10 seconds and make it ideally maybe even 5 seconds, that may be a function of the system in which the study was performed. But as we mentioned earlier in the podcast, intra-arrest cardiac imaging via ultrasound, what does it necessarily add to our armamentarium of things that we are going to do to treat it?
I think it would be fine to do it and to have that pause in CPR if it was a high-yield intervention, right? Something that could produce an actual meaningful outcome, like in traumatic cardiac arrest. We're not going to sit there and plunge on the chest. We're going to perform high-yield interventions.
I would absolutely like to flip the paradigm on its head, and because most of these POCUS out of hospital CPR studies are done, they actively exclude traumatic arrest. I think that paradigm should be shifted to where they should only include traumatic arrest, because what's it going to change? How many people have a medical arrest from just a random tension pneumo or a random pericardial effusion that they just had walking around? Probably very few. I have no evidence to back that up, but just the incidence of random tension pneumothoraces that are profound enough to cause cardiovascular collapse in a medical patient is probably not that high.
Is there something that you can gain by doing ultrasound in CPR? I think there is. Now, you're right, like what in the field with paramedics having the scope of practice that you basically got, yeah, as you said, what are you going to do with it? Probably not that much. That doesn't mean that it's not helpful for somebody out there. Like if you do identify, that he's got a pericardial effusion, or probably more interestingly, like a pneumothorax from CPR.
Yeah, I'd love to be able to walk in and tell an ER doc, hey, he's got a pneumo or an effusion from our CPR.
Yeah, I think there's definitely stuff that can be gained from it. I don't want anybody to think that I'm like 100. As much as I make fun of the ultrasound guys, like I'm not 100% down on ultrasound. Down as in like against it, but it is the question: like, what are we ready for it? Is it something that for the cost and for the training, is it something that's really going to help us out right this minute? I don't know that in our system, in our neck of the woods, that it does.
Yeah, and I don't have anything against pre-hospital ultrasound. I'd love to have it on my ambulance, but I don't know that we're ready for it. If your CPR fraction is less than 80% and your pre and post shock pauses are very long, then clearly trying to implement ultrasound into your management of a cardiac arrest patient is just going to make things worse. I think that if you don't know your survival, if you don't know the survival rate from cardiac arrest in your system, then you probably don't need to be using ultrasound during cardiac arrest.
I absolutely agree. And I probably came off as a little bit harsh and sounding like I'm on the anti-ultrasound train, which is not true. But I entirely agree with what you're saying. We have to be uncommonly good at the common tasks, like having good compression fraction ratios and delivering shocks that need to be delivered and so on and so forth.
I think we can at least agree, some of the big questions. Number one, don't take a study for something that it's not. Like this field study, the data only says what it says. You can't really read much more on that. It shouldn't. None of the conclusion of this ought to be like we should be using ultrasound to do pulse checks, because if you do that, you're just wrong. Like
it's literally not what the study was designed to do.
Yeah, it's not anywhere. It's somewhere. It's mentioned in there briefly, and what the author's conclusion is that we need to have better technology in order to better ascertain if there's a faint pulse or not.
Yeah.
And that's true. Like if you look at everything, that's true. The bastardization of it is the problem. The study says if you have cardiac, or if you have electrical activity and some visible cardiac motion, your chance of survival is better than if you had no cardiac motion associated with. And then also in their setting, they thought people had a lot of tamponade and providers felt like it helped them. And like that's what that one says. And I think that's kind of what you have to take away from it and say, oh yeah, ultrasound's kind of cool, good deal. Let's maybe think about doing that once we get everything else maximized first. Should we shock asystole because it might be fine VF?
No.
Strongly of the opinion not, for the reasons that we kind of talked about. I think that's a lazy man's way of doing it. Should we abandon pulse checks with our fingers?
Yes.
That wasn't the answer I was looking for, but okay.
Oh.
Mostly.
Well, I mean, I think with surrogate markers, I mean...
Do we have problems with pulse checks with our fingers?
If it's a rhythm
that's better.
If it's a rhythm that can't produce a pulse, then yeah.
Because I took that as intra-arrest, should you do a pulse check? No, I'm going to do a rhythm check and look at my end tidal and my pleth.
Yeah.
If I get promising return on either one of those two guys, then I'm going to physically palpate a pulse and see if I have any association.
But if it's VF, I'm not even going to.
Yeah, if it's VF, it's like it's not going to perfuse. So just unless they're an alien, which would be super cool, but like a body snatcher or something.
Is that what you were looking for?
My attempt to close.
We'll try it again, and we'll just cut out literally everything before that point.
So I think we can all agree that pulse checks have problems.
Yes.
And that ultrasound may be an interesting tool to kind of give you another look at something.
Yeah, that's reasonable.
Would anybody make solid decision based on whether or not to start doing CPR again based on your ultrasound currently?
No,
I would not.
Not without more advanced technology.
I concur, and that's honestly my kind of feeling on it. Is it good stuff? Yeah, probably. There's probably room for ultrasound out there. Should we abandon our fingers? No, I don't think so. Not right now. Till you got something much, 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 much better than anything we've got at the moment, which maybe there is out there. What we should probably do is a study on using like a Doppler in your pulse check instead of your fingers.
Hey guys, that's all for this episode. We are now on Instagram. You can find us at Curb to Bed. We're also on Twitter at Curb to Bed, and you can look us up on Facebook so that you can receive regular updates every time we put something out. We want to thank Dr. Lubbers for coming on the show for the second time. I'm sure we're going to have him on again somewhere in the near future. All right, that's all for now. Bye.